So welcome. Paula can't get in, I'm afraid. So you've got me, Beverly Harden, welcoming you to the first of these run of AHP Workforce webinars. And the absolute aim of this is to make sure that as AHP leaders across the system, you are optimally equipped with the information that you need to advocate for the 14 professions, to understand the 14 professions workforce, and to really feel that you have got a handle on the challenges, the opportunities, the magic and the numbers of your workforce so that you can advise your HR directors, your colleagues, you can work with your universities around the incredible opportunity for growth that we have in the next few years to really drive confident AHP responses to service transformation, service development, and also ensuring that we work to address vacancy rates where they are high, retain our valued staff, and really try and keep in service the optimum number of AHPs to deliver what your populations need to optimise their health. So hugely positive piece of work, hugely positive agenda into the next few years. And the fact that we're going into a period of long-term plan delivery and growth is incredible to think that we have got strong AHP leaders across our system with us, which is a wonderful, wonderful place to be able to be starting from. And so this is about empowering you, and it is the beginning of a conversation. It is not the end of the conversation. And as you know, we are investing resource in clinical placements, the allied health professions faculties working at a system level. And the aim of that is to give you support to grow and develop your workforce as well and as intelligently as we possibly can. And now that we're getting the beginnings of some infrastructure, we can really drive that together. And my hope is we get to a point where working with your universities, we can be really clear what the opportunities for growth are in the future and what the opportunities are to really, really drive service transformation and get the AHP skills available to your workforce. So you're going to have to batten down the hatches, a lot of data. A lot of conversation. You'll have lots of questions. We'll answer those all at the end. And really, without further ado, I'd like to take you through into the next phase of the presentation. Sharon, next slide, please, where we can now start to really think about the workforce issues specific to the different professions. And we've got 3 running at each of our sessions. The age-old housekeeping, phones, computers, whatever we're using, on mute, cameras off, please, if you don't mind. We are recording this, please be aware of that. It will be posted on the website and I hope you enjoy it. And please pop your questions in the chat box as we go, because that also means we can then help field those and you can keep them in your sites as we are going through the next part of the presentation. So welcome, and moving on to the next slide, please, Sharon. We're going to do OT, podiatry, art therapy, really get into the guts of what's going on with those professions, and then some lively debate. So get your thinking caps on for your questions, please. Next slide, please, Sharon. So I'm going to introduce you to an incredible lady, Shagufta, who does the majority of our workforce planning and work with us, and she's going to talk you through the OT data. Thank you, Shagufta.
Thank you very much, Bev. Could I have my first slide, please? As Bev mentioned, I'm Shagufta Khan, a National Workforce Planner from Health Education England. Today I'll be talking through the workforce data for occupational therapists, and starting with registration details. Occupational therapists are regulated by HCPC, the Health and Care Council's professions. HCPC regulate almost all the 14 AHPs, with osteopaths being regulated by the General Osteopathic Council. The highlighted column in the table shows how the numbers of OTs registered with the HCPC has changed over the last 10 years. It is seen that in 2008, there were 28,107 registrants on the register, and by the financial year end 2018-19, the number of registrants had grown by 11,818 to 39,925. Please note, the latest HCPC figures show that there are 40,300 OTs on the register as at September 2020. Next slide, please. This slide shows the number of OTs registered with the HCPC compared to the number of registrants employed within the NHS. And here I'm using the NHS digital data source. Please note the HCPC numbers are UK-wide and the NHS digital data is for England NHS only. OT registrants have increased by 11% from 2014 to 2020. A growth of 2% per year is seen. NHS Digital also shows a good increase of OTs employed within the NHS during this period. NHS is only one of the many employers of OTs. As can be seen in this table, majority of the registrants do not work in the NHS in England. This reflects registrants working elsewhere, which includes social care, mental health and education. The recent Skills for Care report has shown there to be around 3,500 occupational therapists working in adult social care sector, with around 2,900 employed by local authorities. Next slide, please. For historical supply trends and supply information, we use both NHS digital data and data from ESR Data Warehouse. As can be seen here, there is a difference in the number of OTs reported by the two data sets, which is mainly due to our ESR numbers are slightly higher as we account all staff, such as those on maternity, and the NHS digital numbers only include frontline staff. However, the trends are largely the same, with both data sources showing a 2% growth per year for occupational therapy workforce. Next slide, please. Sorry, I think you missed the slide. Sorry, could we go back a slide? Oh, right, sorry, okay, next slide, please. This is not the order that I've got it, but that's fine, I will throw this.
It's going to be one of those days, Shagufta. It's like being in clinical practice. We just surf the wave and we don't worry, we'll get the same outcome at the end.
No problem, I can work with this. Data from Health Education England's flow analysis for occupational therapists show that UK joiners have increased from 1,300 per year to just over 1,600 per year in 2020. International recruits has increased from 200 per year to 280 per year, and leaver rates has dropped from 8% in 2014 down to 7% in 2019-20, and they had hovered around the 8% for a few years. The next slide, please. Okay. This table shows the regional breakdown for occupational therapists employed in the NHS in England. The size of occupational therapists employed by the regions is reflective of services provided and the demographics of that region. Next slide, please. Demographics data for occupational therapists shows us that there is a 90% female workforce, and the age profile data for occupational therapists shows that there is 24% of the workforce in bands 50 or above, which is about a quarter, approaching retirement in the not so distant future. However, the good distributions of OTs in the different age bands, especially in the younger age bands, makes it that it should not be too much of a concern. Next slide, please. The ethnicity data shows that 79% of occupational therapists are white British, and the data also shows us that 7% of England's occupational therapy workforce is from an Asian, Black, Chinese, or other ethnic background. The nationality data shows that the percentage of staff with a non-UK nationality is stable around the 7 to 8%, which is around 100 out of our 17,300 workforce. And regional data shows us that 24% of London's occupational therapy workforce is Could I have the next slide, please?
Could colleagues go on to mute, please? I'd be very grateful. Thank you.
HCPC tools have been used to understand the supply and demand requirements of occupational therapy workforce. The analysis shows us that the supply is expected to grow by 2 to 3% per year based on historical trends. Sorry, somebody not muted.
If you hold in 1 second, I will go in and just mute everybody, Shagufta. So just pause for 1 second. This is going to keep on giving today, isn't it? Just enjoy, everybody.
That is not a problem. Can I carry on?
Please do.
Right. Demand is harder for us to ascertain, but we would expect it to grow by the same amount given the requirements within the long-term plan and particularly within social care. But if we want to do more than just keep pace with demand, further interventions will be required. However, this profession has seen solid growth historically, and training numbers are expected to increase in future years. Next slide, please. Okay, in summary, it can be seen that the NHS in England is just one of the many employers of occupational therapists. Many are employed outside of the NHS in England and in other sectors. Workforce data shows us that both OT registration and workforce numbers in the NHS in England increased over recent years, which is driven by increased joiners, especially from overseas. Overall, the prognosis for occupational therapy is reasonably positive due to the solid growth in profession and younger age profile, but further interventions will be needed to secure supply and meet the increasing demand for occupational therapists. Thank you very much, and I'll hand you back to Bev, by the sounds of it.
Thank you, Shagufta. I'm delighted to say that we have Paula joined us. So if we hand over to David at this point, Paula, then you can step into the excitement of a technically enabled workforce in a moment. David.
Thank you.
Thank you, Beverly, and hi, everyone. I'm David Marsden. For those who don't know me, I'm the regional head of AHP in North East and Yorkshire, and I'm an occupational therapist. I'll be picking up questions in the chat box and contributing to the discussion later if I can answer any of your questions. So I'm delighted to introduce Karin Orman, who's the Assistant Director of Professional Practice at the Royal College of Occupational Therapists. Karin's going to present the workforce challenges for occupational therapy profession, key areas for the workforce development and growth, and messages from the professional body about how these challenges can be addressed. Karin.
Thank you, David. Morning, everybody. Could I move on to the next slide, please? That's great. Okay, I am going to just briefly touch on the challenges, but really focus on new areas of development and the opportunities that the professional body sees going into the future. So as you can see, a pre-registration degree covers mental, cognitive, psychological and physical health, as well as social models and environmental adaptations, a broad range of skills that occupational therapists come out from their training. Currently, though, there is issues around practice placement capacity. Students need to have 1,000 hours of practice placement experience, and that is particularly difficult, especially with the recent pandemic, or the pandemic that we're still experiencing. We're also finding that skills are not fully utilised once people would start to advance their career. The way that services are traditionally commissioned and structured doesn't support maintaining those broad range of skills. And we're also finding that to progress your career, there is a push towards early specialism, which is another issue. And also from the data, as you could see earlier, that we do have some regional shortages, particularly in London, and real dependence in London on international recruitment. So as we have new areas of services developing with the long-term plan and the people's plan, we are seeing concerns about robbing Peter to pay Paul as occupational therapists start to go into areas such as primary care, and there's greater development of community services. Next slide, please. But we are seeing growth in the profession and occupational therapists stepping into wider roles, which really utilise their broad range of skills. Recent widening in primary care services has meant funding for occupational therapists working with 3 groups of people. People with mental health needs where IAP services are not sufficient, frail older people, and supporting people with ongoing conditions to return or remain in work. Furthermore, we're seeing restructuring with the development of universal and targeted service delivery, and we've seen that really being led within children's services. At a universal level, we've now got services offering more flexible access to occupational therapy advice for groups such as care home staff, training and advice for teachers in schools, and support for social prescribers. Moving away from one-to-one contact and reflecting this in the commissioning of services can further support this flexible sharing of expertise and increase the profession's reach. At a targeted level, the development of integrated community teams with occupational therapists being drawn from mental health trusts, from social care, as well as with physical rehabilitation backgrounds, means that we move away from condition-focused delivery to more personalised care. And with the long-term plan and people's plan recognising the importance of looking after the well-being of the NHS workforce, we're starting to see occupational therapists also working in occupational health within trusts. This is some of the areas that the profession is now moving into. Can I have the next slide, please? So we have a workforce that's a good fit for modern healthcare need. We have a workforce that has inherent flexibility to work with people early and ensure the adoption of self-management approaches. And we have overall consistent growth, but we need to offer wider entry routes into the profession to draw on a more diverse pool of people. We've seen the start of apprenticeships, but we need to ensure funding and sufficient broad range of learning experiences are offered to support that wider access into the profession. Occupational therapists are also included in the health and care visa, so we need to use that to support when we look at international recruitment beyond the EU. Universities are already offering arm's length supervision in new areas of practice and settings such as schools, and there are existing models of 2-to-1 ratios. We need to sort of take a more regional approach to supporting innovative practice placement provision. And as AHPs generally, we need to resist that pressure of MDTs primarily hosting nursing placements. Advanced practitioner roles are developing, and the development of competencies within primary care will enable occupational therapists to use and retain physical and mental health skills. Our roles and services need to be more widely recognised if we're going to retain and sustain our workforce. There is innovation out there, but the workforce needs to be encouraged to share the data to identify the elements that can be more widely adopted. The lack of consistent data collection in areas where occupational therapists work, such as rehabilitation, for example, means that there is unacceptable variation and a lack of evidence to argue the case for development of those services. And sustaining the workforce is not always about increasing the numbers. We need to be working differently. As you can see, a lot of we've got existing models in social care, for example, which is really using support workers and enabling safe delegation, so that the occupational therapist is supervising and reviewing the complex cases. So this drive towards integration is an opportunity to learn from across sectors. And I'll finish there. Thank you.
Thank you, Karin. I feel like I've joined the circus. I think we actually haven't got the slides up anymore, from what I can tell. I can see Freya. Hello, Freya. And Paul. Hello.
Bear with me. Bear with me. I'll have to go back out.
Oh, don't you love technology? Do you remember once when we used to actually get in a room and we'd be all there together? And this has just been crackers this morning. I'm so sorry. Sincere apologies that I haven't even turned up to my own party until now. It's fashionably late is one thing, but this is ridiculous. So sincere apologies for that. But it sounds like it's Beverly. Thank you for bailing me out. And it sounds like we've covered occupational therapy, which is fantastic. And it's now time to move on to podiatry. So I'm delighted to hand you over to Thomas Speller, who will talk you through the workforce data.
Good morning, everyone. As Paula said, my name is Tom Speller. I'm Deputy Head of Workforce Planning in Health Education England, where I work quite closely with Shagufta on AHP data. Quite like the picture of me there. That was from about, 12 years ago in New York now. Anyway, next slide, please, Sharon. Yep, so I'll be presenting on podiatry, and if there's a takeaway I want to leave you with, the thing to be aware of with podiatry is that whilst for other professions the story over the last decade's been one of quite significant growth, for podiatry it's a different narrative. It's largely been one of, I would say, stability or little change. But despite that, I think there's reason for optimism in the future, because we know, not least from the long-term plan, that there is demand for podiatry services, particularly within primary care. So that's kind of kind of the summary of the presentation. If we go to the next slide, I will begin talking through the detail. So as you can see from the registration data from the HCPC, you can see that for most professions, you can see quite significant growth between 2008 and 2019. For podiatry, it's highlighted, you get quite a different story. You see really numbers not really changing very much over the decade. In fact, by the time you get to 2019 compared to 2008, you're actually slightly below where you were, although it's not very much change. If you go to the next slide, please. And so in terms, and this can be seen in the data, so we can see that really, if you look at the registration data, which is the blue line, we can see that really your numbers, you know, between 2014 and 2020 increased by about 1%. So really small growth, about 0.2% a year, effectively not much change. And that's very different to what you see in other professions where your growth's typically about 2-3%. In August 2020, we can see there's been a bit of an increase, so they've gone up to about just over 13,000. So there are signs that numbers are increasing, so which is a positive story, but what you get is general stability. And what you can see when you compare with NHS digital data, which covers numbers working in the NHS, is that a majority of registrants in the UK don't work in the NHS in England. Some of that will be people working in other parts of the UK. A lot of it will be high employment within other sectors, with podiatry really working in a very wide range of settings. Next slide, please, Sharon. Thank you very much. As Shagufta said earlier, we use both NHS Digital, which is what you see in the public domain, and data we use, which you get directly from ESR Data Warehouse. There is a bit of a difference between the two. So as Shagufta alluded to, we count all employed staff, so that would include career breakers and maternity leave, whereas digital would typically only count those that are at any one time on the front line. What you can see here is, although there's a bit of a difference between the two numbers, the trends are generally, the trends are exactly the same, and both confirm that numbers have dropped slightly in recent years, you know, by a very small amount. What you see overall is one of stability. So next slide. In terms of what we going into a bit more detail, we can see that actually over the last 5 years, numbers decreased by 2%, so about 0.4% a year. We can see some of that will be determined by joiners. So we can see that UK joiners has declined slightly, from about 210 a year to just over 200. You do get movement between different job roles. They largely cancel each other out, but slightly negative, but not by very much. International recruitment's generally quite small, so it's gone up actually, if anything. It's gone up from about 13 a year to 26 and 1920, but we're talking quite small numbers, and a lot of that's increasingly from outside the EU. So in the past, you got a lot more from the EU. It's now going towards non-EEA. The thing that's quite encouraging here, though, is that fewer people are now leaving. So back a couple of years ago, it was 8%. Now it's gone down to about 6.5%. So already there are signs that we are keeping more staff and that retention initiatives are working. Next slide. This just gives you the workforce spread between the different regions. A lot of it will follow where population is, but thing to be aware of just generally when you're looking at regional data, the distribution will reflect slightly how services are delivered in different parts of the country. So in general, what we see for nursing and allied health professions, you see a bit more in the north normally compared to London, and that will reflect partly in terms of the needs of local regions, but also that historically you've tended to employ more compared to London, which tends to employ more doctors. So yeah, to have that in the back of your minds. Next slide even. So we get into the demographic information here, and the thing that's quite striking here is that 3/4 are female. Actually, quite a lot of men in this profession, so over a quarter. Normally, you see a lot more women in allied health professions. Thing that marks out podiatry compared to other professions, it's an older age profile. So you see quite a lot over 50, just over a third. It's a bit better than it was a few years ago. If you'd looked at it from 2015, more skewed to the right, but certainly it's a contrast compared to other professions where you see a much younger age profile. So what you'd have seen for occupational therapy, for instance, and this is quite significant because really the old age profile means that there is a risk associated with an aging workforce, but one that we seem to be beginning to mitigate. If we go to the next slide. Thinking about ethnicity and nationality, and apologies for the small writing here, but what you see in terms of ethnicity, majority are white British. Colleagues from BAME backgrounds make up at least 13% of the podiatry workforce, and that's quite close. It's closer to the median. It's higher than occupational therapy, as Shagufta would have explained. In terms of nationality, quite small numbers from outside the UK, but it's increased from 3% to 5% in the last 5 years. Really small numbers, about 140 out of around 3,000 in the workforce. Thing that's quite clear in terms of regional spread, much more in London, and this is consistent throughout all the allied health professions. You just get more in London, and you see this in really all professions. Next slide. In terms of summary then, all else equal, based on what we've seen historically, we would expect little to no growth without further intervention. And that's just historically, it's been the same story for the last 10 years. Whilst growth and demand is harder to ascertain, conservatively, based on what we've seen in the long-term plan and what we know primary care would like, we would expect demand to grow by at least 1-2% a year, if not a bit higher than that. Now, if you look at no supply growth, all else equal, some growth in demand, you do get a bit of a scissors effect here. It means that you need to intervene quite a lot, not just to keep pace with demand, but actually meet it in future. So if we go to the final slide, what's the implications of this? Well, the prognosis is, historically, it is more challenging compared to other professions. We know because you've got an ageing workforce, your supply really has been quite flat, and we know demand is going to increase. And we know that, and this has been a long-term thing. If you look at registration data, this is not something that's happened in the last few years. It's been really over the last 15 years. But what we're seeing in the long-term plan is that there is increased demand for podiatry services, and that really offers us a great opportunity to really promote the podiatry profession, attract more students, and really meet demand. And there's already efforts underway, not least in improving retention. But the thing to be clear here is this will be quite a long-term piece, and we'll probably you would need to look at managing demand as well. But so challenging contexts, won't deny it, but I think given the increase in demand, some cause for optimism in the future.
Fantastic, thank you, Tom. Thank you very much. Now, I'm not sure whether we've got Rebecca with us. I don't know if she's had any technical problems like many of us have. So, Rebecca, are you there?
I'm here, yes, thank you, Paula.
Fantastic. Right, well, I'm delighted to hand you over to Rebecca.
Okay, thank you very much. So yes, my name's Rebecca Tyrell, and I am one of the acting Health Education England regional leads for South East for AHPs. I am a podiatrist by background, and I've had the privilege of being working with James Coughtrey, who I'm going to be introducing now from the College of Podiatry, who's going to be giving you an oversight about the workforce challenges for podiatry, the key areas of workforce development and growth, and then a message from the professional body about how these challenges are going to be addressed. So thank you very much, and I shall hand you over to James.
Thank you, Rebecca. Good morning, everybody. If I can go on to the next slide, please, Sharon. So as things have identified, we in podiatry have a number of multifactorial issues that we have been challenged by over the last 10 years. And we've been slowly and carefully working through those issues to try and build a consistent, reliable workforce. We have a number of concerns across the profession in terms of position, but we are starting to see some positives over the last couple of years. So if we start with supply lines, and we have had a reduction of some nearly 40% in student numbers in the last 3 years, and over the last 10 years that has been slowly incrementally decreasing as well. So there's a net effect of a significant loss to our incoming recruits. Most of the data that we've seen about the next academic year suggests that we should have a quite substantial uplift of about 150% for the next academic year. Now that could be in part down to the COVID effect, where potential applicants are reconsidering their options, where they are less likely to travel, they're probably less likely to be in a work role, and maybe thinking about retraining, and the support funding that's in place for podiatry and other AHPs maybe enticing them into podiatry as a profession. Alongside substantial work, it must be said, that's been done by HEE, by the Office of Students' Strategic Interventions in Health Education Disciplines programme, and by the college itself. We're really hopeful that is more than just a bubble, and that we will continue to get a substantial increase in recruitment and year-on-year growth for the profession. We have a significant number, as Thomas has identified, of the overall workforce that are due to retire in the next 5 years or so, and we have a current vacancy rate in England of about 8%, which tends to suggest that there's a lot of opportunities to look at podiatry service delivery and think about innovative ways of delivering it. We have struggled with the alterations in service provision that have happened over the last 10 years through various different policy implementations, and we're now at a stage where the full spectrum of podiatry services are really very rarely met within service, and we need to look at how we can engage in role emerging activities and novel practice for the profession, which we can parry up with commissioning of services for the future. We have, as Thomas has alluded to, a number of our staff and a number of our workforce work within the private sector, either fully or partially, and that creates obviously an efflux out of the NHS, and that efflux is not just in terms of the resource itself, but also in lots of cases it is more experienced colleagues that are leaving the NHS, and so there's a knowledge gap that is slowly developing as a consequence. So we have an interest there in trying to improve the working conditions and the work-life balance within the NHS to try and establish a real attractiveness to working in the public health sector. We've had variable uptake and use of support workforce across the profession, and there's some really great examples of really maximising the use of podiatry assistant practitioners and other support workers to enable us to meet the service delivery demands. There's further work that we need to engage in to really establish that. From a clinical education perspective, our placement capacity generally is reasonable given the size of the profession, and the likelihood that a fair number of our education providers have central clinics and central training facilities within their university settings that can meet some of that demand. But like I say, with the role emerging activities and the novel integration of podiatry in different areas, we would like to see more expansion into different areas of placement. So I'm very happy to pick that conversation up as we go along. Next slide, please, Sharon. So in terms of key areas for development and growth, we're looking at trying to help service leads and system leaders appreciate and understand the full spectrum of podiatric practice. COVID redeployment has given us a great opportunity to build on the existing relationships we've had with district nursing, with acute services, with vascular teams, with dermatology, rehabilitation services and falls prevention, and others as well beyond that. And we feel like there's a fantastic opportunity now that exists with the mentions in the long-term plan and the people plan to really try and push on and give podiatry a more solid footing across the whole spectrum of primary and secondary care. We know that there's been alterations in practice that have taken place, and where they've taken place, they've been really successful. So the example we've given here is the extension of independent prescriber status, and bearing in mind that podiatry is probably the only AHP that has the full spectrum of prescription-only medicines and independent prescriber status alongside use of PGDs, supplementary prescribing, etc., etc. So, as a professional status goes, we're really comfortable and really well trained in utilising pharmacology as part of our practice. We're looking how we can embrace advanced clinical practice and develop frameworks into relevant MDT services and podiatry services. We know that there are frameworks that are in development in partnership with HEE around the high risk lower limb, MSK, and specifically podiatric surgery. And we now have a specific HCPC annotation for podiatric surgery, which hopefully gives a real sense of robustness to the training of podiatric surgeons across the country. And there's fantastic opportunities being explored currently around multi-professional foot and ankle surgery teams, partnering up with vascular surgery, partnering up with other departments, looking to expand the role of the podiatric surgeon in delivering good foot and ankle care. We have an opportunity as well to deliver different service models that may be able to include the support workforce in far greater number and in far greater spread, and that hopefully can enable the rest of the workforce to work to the top of their license. One of the concerns that we have is that across the country there's a patchy variation in the way that podiatrists are deployed effectively. So we would really welcome that opportunity to look at service models that enable the support workforce effectively. We also need to look carefully at how we can build in clinical education structures in the workplace setting to support the education and training of the next generation. The college's position is that it is the responsibility of all regulated and registered podiatrists to support the next generation of the workforce, and we really need to look carefully at how we can encourage and enable everybody to play a part in that process. And we really need to avoid in that mixture that efflux that I mentioned of the knowledge and skills of those more experienced senior colleagues that are leaving the service and moving primarily into the private sector, but also into other sort of commercial and academic roles. How can we retain them? Next slide, please. So our key take-home messages for the AHP leads amongst you is to explore and understand the roles that your podiatry team could be undertaking. There are several opportunities there that for service enhancement that are probably not being taken, and the college is very happy to help where it can to support this activity. We'd like to continue to support recruitment and outreach activity and embed preceptorship frameworks to enable junior staff. We're really conscious of that need to mind the band 5, 6, 7 gap that is in existence, and make sure that pyramidal hierarchy that currently exists enables good staff development, and we're not leaving people in band 5 and band 6 roles for large portions of their career and switching them off from their interest and encouraging them to seek opportunities elsewhere. We need to look at the opportunities for developing the support workforce further and build capacity in the rest of the clinical team. There may well be a number of opportunities that come about in the future for really enhancing the offer that the support workforce can bring. And certainly when we look at the apprenticeship models, there's great educational structures in place now for both support worker apprenticeship training, and then leading on from that, taking the support workforce into the regulated profession through apprenticeship programs, both at undergraduate level and as MSc pre-reg fast track routes. We really think it's key that we look at how we develop the next generation of podiatry leaders, and trying to encourage podiatrists amongst your teams to push forward in leadership roles will really help your service and really help patient care delivery, but also support the profession in starting to meet these wider aims that we've got to really tackle. And we also need to look carefully at how we embrace portfolio careers in that mix, and how we ensure that clinical delivery is met, but also that we encourage staff retention through development. We bring in those additional skills and knowledge that they may have from working in the private sector, in education, in research, in third sector and professional body aspects, so that we get a more rounded and more thorough delivery of service overall. I've left that contact up there for people who want to make contact with the college and get in touch with us. We're very happy to engage in all and any conversation about your thoughts about how we can take the profession forward. And I'll pause there and pass back to Rebecca.
Hello, it's actually passing back to me, James, but thank you so much for that really good presentation, really interesting and helpful to people. So we're now going to move on to our third and final AHP of the day, which is art therapy. And I'm now going to hand you back over to Tom, who's going to talk to us about the workforce data.
Thank you, Paula. Hello, I've introduced myself earlier and you've seen me, so I won't repeat that again. If we go to the next slide. Yep, so I'll be talking about art therapy, and the thing to make clear of this one is that in terms of what we tend to see in workforce data, a lot of it tends to be grouped with music and drama therapists, so it's a thing to be aware of from the outset. Where possible, I will make a clear distinction between arts therapists, which is the three groups clumped together, and art therapy. But the thing I'll be clear on is that certainly for art therapy, it's where there is potential for improving the data in this, not least because we know just from observed data that things tend to be grouped together. If we go to the next slide. You can see in this case that that's what exactly you see in the registration data. In terms of the overall trends, we've seen occupational therapy tends to follow most professions, about 2-3% growth a year. We've seen for podiatry that growth by contrast being quite stable. Arts therapists is again a slightly different story, quite rapid growth over the last 10 to 15 years. As you can see, we're about 2,500 in 2008. It's gone up to just under 4,500. 76% growth in 12 years up to 2019. About 4 or 5% growth a year, which is quite rapid. If we go to the next slide. So, and you can see this quite clearly in the graph. So if you see the blue lines registrants, you can see quite a clear upward trajectory. In the last 6 years, arts therapists grew by 32% or 5% a year. In recent times, the evidence suggests it may be slowing down. We've only seen an increase of about 30 in the last year and a bit, so it may be slowing down, and this could be a result of current circumstances. Historically, we've seen quite big growth. The thing that's really apparent here, and when you look at NHS digital data, is that really the majority of registrants in the UK do not work in the NHS in England, and you can see that in the green line, numbers are very small. We're talking less than 500 FTE arts therapists, and this will reflect the fact that they will work in a wide range of settings. So particularly within education, you get quite a few of them there, a lot in the third sector, a lot in charities, some in private practices. The thing to be clear, a lot of settings, and the NHS is really a minority employer in this regard. If you go to the next slide, please. Right, so when you look at the supply trends, again, as I said earlier, we use NHS Digital and ESR Data Warehouse, small differences, but confirm the same narrative for arts therapists, growth of about 3 to 4% a year. What I've done here is I've actually picked out art therapists, which you can do via the job role in the ESR Data Warehouse. And what you can see is that, overall about 400 to 450 arts therapists. When you look at art therapists specifically, it's about 75% of that group, so just over 300, and they all confirm the same narrative, about 3-4% growth a year. If we go to the next slide, please. Yep, so as you can see, 3 to 4% growth a year. Your numbers are generally quite small, so worth having that in mind. Your growth in domestic supplies gone up from about 15 per year to 35 in 2019-20 in the NHS. Might suggest that more services are being delivered in the NHS with greater numbers. International supply is really quite small. You're talking about 5, historically about 5 FTE a year, went up to 10 in 2019-20. Your leaver rates, as with other professions, have dropped down to about 5 to 6%. General theme here, we just need to be aware of small numbers here. So you will get fluctuations over time, but overall we tend to get more people and they tend to be staying longer. If we go to the next slide. Just the geographic spread between them. I think it's quite clear here is that you have a lot more in London, and that will reflect in terms of how services are delivered. So just worth having that in the back of your mind. If we go to the next slide. Into the demographics, quite interesting. Actually, quite a lot of men in this profession, about 20%. 80% are female, so about 350 arts therapists in total. Quite an old age profile, actually. About 40% are age 50 or over, only 5% are under 29. And unlike with podiatry, it's a different circumstance here. So with arts therapy, you typically need a postgraduate degree. So often you will not be starting until usually you're in your 30s. So the fact you've got an older age profile some of that will be because of the fact of when you start, and it may also reflect when people actually join the NHS. So you may do a number of years working somewhere else and then come into the NHS at a particular stage of the career. I mean, this would be something that, you know, might be worth thinking about. Next slide. In terms of ethnicity, majority are white British, just over 3/4. Very small numbers from BAME backgrounds, so only about 4%, so really below what you might expect. Interesting to get thoughts on this. In terms of nationality, numbers have gone up quite considerably, from 7% in 2015 to 12% in 2020, and this, in terms of scales, you're looking at about 50 arts therapists specifically. As with other professions, a lot, London employs a bit more non-UK nationals. Interestingly, you get a bit more in East of England as well, about 1 in 10. And if you're not British, you tend to be Irish, American or Greek usually. Next slide. No, just waiting for the next slide to come through. Yeah, so based on what we've seen historically, we would expect pretty solid supply growth, because we've seen historically about 4 to 5% a year. Need to be aware that your numbers are small, so could be subject to fluctuations, but it's been consistent over the years, quite strong growth. The uncertainty here is around demand. So whilst we might have expected similar-ish sort of growth pre-COVID, what we're hearing is that demand for these professionals will increase considerably, not least what we know in the LTP for both mental health and psychological therapies, and arts therapists will need to play a big role in this. So whilst this is a challenge in a way, because we're meeting, we will need to meet increased demand, this is a good opportunity for the profession as well to really have affect NHS services. So whilst we would be saying that supply growth is pretty solid, actually we know we will need more investment in this profession really to meet the demand that we want to provide in future. So in terms of the final slide, as a summary, a lot outside the NHS in England. What we're seeing is that might be that's changing over time. Considerable increase in numbers. Overall, I think the prognosis is positive. We've seen solid growth, but we know that we're going to need to respond to increased demand in future. And so whilst this will be challenging because we will have to invest a lot more in it, it's actually a really good opportunity for arts therapists and art therapists as a whole. And that's it.
Okay, thank you very much, Thomas, and thank you very much to Shagufta. I'm now going to hand you over to Val Hewitt, who is our CEO from the British Association of Art Therapists. But before I do, I just want to apologise for the slides that I may have. They don't quite look as fantastic as they did when Val sent them to me, because I've had to do some cutting and pasting. So apologies in advance. But thank you, Val, for joining us.
No worries. Thank you, and thank you, Thomas, very much for this presentation of the data. And I really agree that there are opportunities, and it's probably a question of really working together and using our collective imagination. So I've used the art in the slides to show a bit of this. So next slide very quickly, because it's an acknowledgement, and then the following slide would be lovely. Thank you. So the current context is that the data is actually really difficult to get because we work across 3 fields mostly. So of course we're AHPs, but we're also employed in psychological therapies departments. So sometimes we're not managed by AHPs. And you also find us in what's called arts in health. So these are artist-led projects in health and social care and education. And we come under lots of different titles, which I'll see later, but we often combine several part-time jobs, and we combine employment and self-employment. So for instance, last time we did a workforce survey in 2018, it showed that 43% of our members worked in the NHS and 50% in the education sector. And that's the education sector includes early years, primary, secondary, higher education and special education. Now, this 43% and 50% will include people who work in both sectors, because they work a bit part-time in the NHS and a bit part-time in education. So they actually getting hold of the data for the workforce is a little bit of a challenge for us. But we do identify very strongly as a psychological therapy first and foremost, and we work across all these kind of other areas using our primary skills as psychological therapies. Next slide. We have got a few challenges. So as I said, we're employed under a lot of other titles, and we may be, for instance, in the NHS in children and adolescents mental health services, but we're not there as art therapists, we're there as mental health workers. So you may not even know that in your trust you are actually employing art therapists. We have a lot of regional differences regarding inclusion in terms of what trusts think should be core professions in their staff, and it's actually a bit disappointing that sometimes they consider the arts therapies as not being a core profession in what they should be delivering, and it really affects what our service users can access. So there's a real inequality depending on where you live, and you may either have access to a fantastic arts therapy service, or you may have absolutely nothing. And this is really unfair for our service users. And it's a bit the same with practice placements, because of course, where you don't have arts therapists employed, then you don't have practice placements. So we have like deserts in certain trusts and a really good provision in others. And it makes a big difference, as I will say, to patient experience. Now, we also have, in terms of psychological therapies, a very restrictive interpretation of improving access to psychological therapies. Those of you who don't work in mental health may not remember, but Lord Layard, a few years ago, introduced this program called IAPT, and it was very much about helping people who may have mental health problems to get back into work. And unfortunately, it was a rather simple solution to a very complex problem. And it's actually the law of unintended consequences, which means that one approach, which is cognitive behavioral therapy, has been dominating a lot of what service users are offered. And whilst it works very well with many, if you can't get engaged in that approach, then you don't have very much else to kind of like help you. And again, there's a kind of a bit of a worry about people who fall through the net and have got no help that can really fit their needs. Next slide, please. Can I have the next slide?
Can you see it now?
Nope, I can't see it. It's not being posted yet.
Is it the one that says how can we help?
Yeah.
Yeah, that's I can see that up on the screen. So I don't know where.
Can everybody see that?
Can somebody else?
Yeah, we can all see the how can we help slide.
Yeah, I can see it.
You can see it, that's fine. Then in that case, might be my one. I'll carry on. So how can we help? Right, we have, as Thomas was saying, a really mature workforce. And interestingly, we also have shortages of certain professions in mental health, in the mental health workforce. So for instance, psychiatrists are rather low on the ground, and that really creates a pressure on the workforce. And we really need to diversify this workforce to meet these needs, all the needs of our service users, which are becoming quite, a lot more kind of complex at the moment, especially following on from COVID. So in order to kind of meet the pressure on the workforce, we can really help. Now, we have a continuing strong intake of graduates on training. There is no shortage of people who can come to help this shortage of in the workforce. We have engagement through art with marginalised service users, and that's really important. As I was saying just a few seconds ago about cognitive behavioural therapy, some people cannot use verbal approaches and they really need help. So we can do that through the art really effectively. And we can do that specifically with children, young people and families who are really disengaged. And as we know from the evidence of childhood adverse experiences, prevention is better than cure. The earlier you get in, the better the prognosis. So there is something that we could really help with. We also support staff in health and social care with work-related stress. And we had some amazing examples during COVID where some volunteers visited people who were isolating and to deliver medicines, and were actually quite traumatized by the stories that they heard from service users who were having to stay at home. And we had to kind of come in and actually provide some support, which was really nice. We have some innovative management and leadership skills, actually using the arts sometimes to work on videos, to work on messaging, to work on communication is really useful in leadership skills. We also have a co-production ethos with service users, and that really helps for service redesign. We can involve service users around the arts to kind of help them to really share what they think and what they, and to actually to pursue that type of ideas about service redesigns and include them really actively in that. Importantly, we're also a bridge back to the community through the Arts in Health partnerships and also through social prescribing. We've had some amazingly innovative projects on social prescribing, but art therapists working with other HPs in the community to really try and make people feel connected and not isolated. And of course, since COVID, we've had a blossom of experience in digital art media. Now that we can share with everybody, that is incredibly efficient at putting a message across. So next slide, my last slide. I'll take it, you will all see it. Shall I go on to just say it? It's a take-home message for HP leads. So what we do know is that service users really highly rate their experiences of arts therapies, and it really makes a difference to the patient-reported outcome measures when they have access to arts therapies. So if we improve access to the arts therapies, we would really support a better patient experience all around. Another issue is that mental health distress is not found exclusively in psychiatric services. So the connection between mental and physical health is well established. And I really liked Karin's point earlier on about we really need to think about how we design and deliver our service. Let's not let a crisis go to waste. Now is the time to really think about innovative service design. And I think if we can work together on that, we could boost the whole of the AHPs. So integration between mental health and physical services would help everybody. We can really help to advertise AHPs because the art is our best advert. We can share this widely and we can be better represented. And the main message is that as art therapists, we do more than art, but with art, we can do more. Thank you.
Thank you, Val, and thank you for the beautiful slides with the fantastic artwork. Okay, so that really has been a lot of information in a short space of time. So just before we move over to the discussion, I just wanted to bring your attention to a couple of points that I would have told you about at the introduction had I been able to get on the call. So it's really just a little bit of context about the background to these webinars. And so during September, we're going to be delivering 5 of the webinars, which I believe Beverly probably will have told you, but they are actually a follow-up to our AHP faculty virtual showcase that we had in July. And for those of you that don't know, our AHP faculties provide an infrastructure to allow our systems to actually address their AHP workforce issues collaboratively under one roof, theoretical roof, so that they can work better and more efficiently and collegiately together. So the recent evaluation of our faculties, we have 24 faculty test beds in the country, and the recommendation has been from the evaluation that we should all be asking for data, and we should all have a data dashboard about our AHP workforce, and we should be using that data to understand our faculty's means of and ability to problem solve, and the data should be at the heart of prioritising our workforce agenda and the initiatives that we use to solve some of those problems. So it's rooted, these webinars are rooted in our AHP faculties. For those of you that don't know about them, please contact me if you're interested to find out more. But the aims of the webinars have been to provide the information to our chief AHPs so that they can have those conversations with their HRDs and stakeholders about workforce, so that they've just got that more information. The combination of the data combined with that information from the professional bodies will hopefully provide you with some really useful, valuable, strong tools to go and advocate for your AHPs. So I just wanted to just give you that context, which, as I said, I would have done in the beginning, so apologies for that. And I'm now going to just see what David's got to say about, sorry Sharon, can you go back one please? Can we just ask David what's happening in the chat box, because it looks like it's been incredibly busy with lots of conversation and networking. I just wondered if there's anything, before we actually have people speaking, is there anything that we want to flag up from the chat box that requires somebody to respond?
Most things have been picked up during the chat box. There's lots of excitement about things that Beverly said about podiatry support workforce and people asking for information about that. A couple of debates about prescribing, but everybody's answered each other's questions, or we have really. In terms of occupational therapy, there was a bit about sometimes people not being prepared for certain specialisms when they come out of university, but basically that's about the distribution of placements, isn't it, and good preceptorship. And there was also a mention about, and I think this is general really, not just for occupational therapy, but there was a mention about spare placement capacity. And I hope the regional leads are okay with this, but I've directed people to them, because I'm sure I would be delighted if people would contact me where they had spare placement capacity. But regional leads may have systems in place, but they can direct to that. I think a little bit of a debate about ADI, but mostly comments around the backgrounds and the qualifications and experience. I think that about sums it up, but I don't think there's any hanging questions for us to pick up in the discussion.
Okay, brilliant. Thank you very much for that, David, and for keeping your eye on all that. That's not an easy task. So, right, sorry, Sharon. We're not quite there yet. Let's go back to the discussion page. So now it's your opportunity if you would like to ask any of our speakers or Beverly or any of our regional leads or each other. You can pop your hand up and we can take questions, because we've got a lot of experts in the room, a lot of experience. So it's over to you now. Is anybody going to kick us off with a question or a comment? Gosh. No, I don't think people obviously don't want to speak out loud. They've obviously had the questions answered through the chat box, which is great that that's been used. Oh,
Paul, one thing that's just popped up is just about making arts therapies meaningful and accessible to our clients from BAME backgrounds, and I think that's a relevant point across all professions, and we're focusing focusing a lot of energy on that in the moment in terms of AHP careers promotion and also everything we do. You know, I suppose there's been a bit of a stimulation through Black Lives Matters, so everybody's considering allyship and how we can listen to lived experience and make this part of our kind of architecture. But in terms of promoting AHP careers, we're thinking very hard about that. And through the faculties, we know that some people have got specific projects around EDI, and we're hoping they'll be shared, aren't we, through the faculty network. So that is something we're considering very carefully through all of our professions. I think there's only one of our professions that matches the national average or the population. So yeah, just to mention that.
Thank you. Right, we did have some hands up, so let me just see if I think there was Tanya.
Hi, so I'm the OT lead at Friendly Health in Surrey. I just wanted to add on to kind of the discussion point in they were saying about shortages. London came up, but actually the South East is having some real challenges as well. And I would say that that's across sectors: social services, intermediate care, acutes. In contact with many of my colleagues, and recruitment is a real challenge for us in this area. Partly due to cost of living, partly due to the fact we don't have universities kind of on our doorsteps. But I know my colleague Sharon has also flagged there, you know, we have had placement capacity through COVID, and have an ongoing issue really where placements aren't uptaken by universities. So, you know, this constant drive of there aren't enough placements, actually there are people willing to offer placements, but quite often they're not taken up.
Thank you.
Come back, Paula, is that okay?
Of course, yeah.
That's brilliant, thank you. So what's fascinating for us when we look around the regions, and Rebecca and Lucy are sort of deep into this space, is the South East is a really interesting sort of system and or ecosystem in its own right. So I think there's a bit for me about I would really value Rebecca and Lucy working with colleagues across the South East to really get under the skin of exactly what you've just talked through, because it's incredibly important, because actually from London, the South East placements are vital, and Laura is struggling so unbelievably with placements in London for certain key professions that actually by taking, and I know you do that a lot at the moment already, but I think there's just a bit for us about how we really start to connect better. But I'm also really interested, if you look at the numbers of growth that we need to achieve in the next few years, it is enormous. And so I would suggest to you that, again, if you've got placement capacity in the South East, appreciating cost of living is tricky, I get that. But actually, if there's a way that we can support you with increased growth, be that around apprenticeships, be that around traditional undergraduate supply lines, really, really keen to have that conversation. So Rebecca, could I ask you to connect that up in region and perhaps bring Laura in some of the conversations about how we might be really clever?
Absolutely, will do.
I'm really happy to talk to anyone about that. And just as an example, we looked at our student offers, and basically we've had 20% taken up of the offers that we've made. So
fantastic, because we're going to need every other one of those 80%, and it's one of those careful what you wish for moments, Tanya. So engage with caution, but we'd love to have that debate with you.
Thank you.
Sorry.
Richard? Oh, who's that? Sorry.
Sorry, Paula, it's Karin from the Royal College of Occupational Therapists. I would also say if link in with us and we can have a look at what we can do to promote that as well. You know, we talk closely with the universities and we can highlight this as an issue.
Thanks, Karin. Richard Sharp, your hand's up.
Yeah, hi there, thank you. I'm sort of deputy head of podiatric surgery in EPUT, which sort of is in the Essex area. I was just sort of quite interested with regards to the Podiatric Commissioner's Toolkit. I think certainly from a national perspective, podiatric surgery has been in a COVID pause position. And I think sort of everyone's now strategically looking at those restarts, and I just sort of trying to go, I think that would be really welcomed to get that support, and was just trying to work out what the time frame of that might be.
Is that something that James would like to pick up on?
Yeah, thanks, Paula. Thanks, Richard. Yeah, absolutely. I mean, the college's Faculty of Podiatric Surgery is developing that Commissioner's Toolkit as we speak, and the likelihood is that it'll be ready to go in the next probably 6 months, Richard, I would say. They are aware behind the scenes of a lot of the issues that are still at play with the variability of service access and activity around podiatric surgery, and I would say where possible it's always a really good idea to try and link back into the Faculty of Podiatric Surgery so they can support you and develop the arguments both locally, regionally and nationally for the good of podiatric surgery.
Thanks very much. I'll make those links and see if I can put my oar in, as they say.
Thank you. Thanks.
Thank you.
Paul Chapman. Hello there. I think your hand's up, Paul.
Yeah, no, it is. No, it is. Sorry, typing away. Morning, everybody. Thank you very much. I've posted in the chat box. I've got to say it. We mustn't forget return to practice. There's a real workforce out there with mass experience, And what we've noticed with the COVID and the bring back staff, a lot of individuals were being placed on the temporary register, and we've seen some data that actually says those individuals would be willing to return back to practice. So my plea to you is, if you get a knock on your door or you get an email into your inbox from a returnee, please look at it in a positive way. The response that we've had so far from all of the returners has been great. We will be running a webinar in a couple of weeks' time around return to practice to get you all up to speed on it, but for me, it's return to practice is a way of helping towards the workforce issues that we've got, and across all of our AHP professions. I know not osteopathy, but because they don't have to follow HCPC, but even those individuals want to return to practice. So yeah, that's my plea to you. Thanks very much.
Thank you, Paul. Simon? Simon, I think your hand's up.
It is. Sorry, just coming off mute. Thank you. Just going back to this question about placement, I sit on a national group called the Placement Advisory Group, and it's something that COVID kicked up or signposted to a potential problem. It's one that's been bubbling around for a while, and one of my colleagues down at Wessex manages, I think, the problem quite well with a thing called a knitting pattern, looking at capacity within the trusts and who's actually on programme and when those HEIs want to use that capacity, and it's not as joined up as it should be. We're trying to roll that up to a national scale. There's a new student data collection now, so that we have standard national student data from the HEI, so you can much understand that massive training pipeline across all the specialties that sit within the NHS. So this is being looked at. It's in very much an embryonic stage at the moment, so I'm not quite sure how we can influence or how we involve HEIs and how we influence, because obviously they don't belong to the NHS, they're a separate entity. But one thing is for certain, that the capacity problem lies with the trusts, it doesn't lie with the HEIs. The HEIs, if they want to expand any programme, it's in their interest to, because it's money at the end of the day, but ultimately to absorb that capacity, and particularly with the larger groups like adult nursing, we have to look to the trust, because if they can't take those necessary student placement hours, they're stuffed, and there will be a backlog, and then we'll have all sorts of problems of trying to get them to complete their hours before the end of their course. So just an assurance statement from me, really. It's something we're looking at. We're not there yet. We're not quite sure the direction which we're going, and we don't have all the necessary tools yet. There are a couple of tools in development, one of which done by myself, which we're hoping to scale up to a national level, so that we can have a better idea of managing that all-important training pipeline, which is incredibly complex.
Simon, that's brilliant. David Marsden's just about to kick off a fundamental programme of placement rethinking, really. It's our little revolution stimulated by the £7 million that we have been given to drive this transformation. So I put David's email address in the chat box. Simon, could I trouble you to get in touch with David so we can support and understand how we build on the genius in the system already, not reinvent things?
No, of course, and I'll feed that into the placement advisory group which I sit on. But yeah, there's obviously differences. There's demands at different times of the year. Typically, there's no demand over Easter, summer holidays, and Christmas.
At the moment, Simon, that could change fundamentally
exactly.
if we double our student numbers.
I think it will do, and also there are some trusts that are not favoured for obvious reasons. Geographically, they don't suit. But that said, if you want to see geographical differences, we've even got Strathclyde University's placed students in one of our East Kent hospitals. So that's how far people sometimes travel. And when you see the map, you look at that, look at the geography and where everybody sits, and the movement of students across to all the different trusts, particularly from Bournemouth that cover a lot of the west and some of the central south, maybe not as far as southeast. It's huge, it's massive.
Thank you very much. Thank you, Simon. OK, we've run over time slightly because we had a bit of a rocky start, so I just wanted to leave you with some final thoughts and one final ask. So thank you to all of our presenters, Beverly, our regional leads, and thank you to the behind the scenes team, Sharon Kibble, Megan Hughes and Jane Gardner-Florence, and also to my very critical friends, Helen Lycett, Vicky Lightwood and Susanna Preedy, who have helped me to shape the webinar. We've got 4 more sessions which will cover all of our other AHP professions, and we will look at the links to that to make sure that they run a little bit more smoothly. But those dates run through September, so please join us for those, which will follow the same format as this, but just for the other professions. If you want to find out more about the AHP faculties or setting one up, please get in touch with myself. And finally, can you please add in the chat box anything else that you would like to know about your AHP workforce, because we can then use that information to build and develop future webinars for you and make sure that we really are answering your questions. We are going to be working with NHS I&E to put something on around leadership and career frameworks for AHPs, because that is something that you've expressed an interest in. We are recording this session, and we will put the recording along with the slides onto the HE website. So look out for that, because we'll be doing that as soon as possible. Okay, so thank you so much for attending. Sorry about all the original technical issues, but I think I hope you'll agree you found it's been really useful, really interesting, and best of luck. See you next time.